Hello, everyone. Welcome to our learning community, Invisible Wounds of Service, PTSD, TBI, and moral injury. It's a three-part series. So today we're going to be doing session 1, which is focused on post-traumatic stress disorder. Next slide. So some of you may know me already, but for anyone who does not, my name is Chantel Boudreau. I am a project associate with SAMHSA's SMVF TA Center. So I'll be moderating. Next slide, please. Before we get too far into this, just want to go over our disclaimer. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of SAMHSA, HHS, VHA, or VA. Next slide, please. So our agenda today, we're going to be doing our welcome. We have introductions and overview. We'll be doing presentation part 1. Then we're going to take a pause, have some time for Q&A, as well as some facilitated discussion. After which we'll do presentation part 2, so the second half of the presentation. And then we're going to have additional Q&A and facilitated discussion, and then we will wrap up. Next slide, please. So just want to go over ensuring a safe and inclusive virtual meeting space. So if you're going to be chatting and asking questions, it's very helpful if you have your name set to what you want to be called, so that it just makes it easier, so we're not trying to refer to you as iPhone. So that would not be your name. And then also, we really do ask that you please disable any AI transcription or recording services, and please only use Zoom's live transcription setting. You can turn your video on when we're doing any discussions. It helps, with engagement when we have those Q&A and whatnot. Additionally, if you're not speaking, obviously we would ask that you please mute your microphone so as to not disturb others in the meeting, and to please raise your hand or use the chat function. So you can use the chat to ask questions. And additionally, with the raise your hand feature, we please wait to be called on. It will let us know the order of which people raise their hand, so that we can just be respectful of others. Next slide, please. So the objectives today are to educate attendees on the definition, symptoms, and impact of PTSD, as well as inform on the prevalence of occurrences among those who serve, to present findings and clinical practices related to PTSD, and to inform attendees about available resources, support systems, and treatment options for those who are affected by PTSD. Next slide. So I see some people have already started this, but for anybody who has not, if you can please in the chat, if you want to feel free to put your name, agency, let us know what state, territory, or tribe you go with. If you're on a governor's challenge team, mayor's challenge team, crisis intercept, mapping, suicide, and mortality review. And if you know what that is, then you know what I'm talking about. If you want to feel free and put that in there and see if there's other people on those, please feel free to do so. Next slide, please. All right. Next slide, please. All right, so we have a poll. Did you attend the November 5 webinar on Invisible Wounds of Service, PTSD, TBI, and moral injury? So for some of you who attended it, this is going to be an extension of that, but we will be still covering some of the basics as well for those who did not. All right. Give it a little bit more. Can we go to the next slide, please? All right, so I just want to introduce our presenter, and then while that's going on, I'll visit the chat. But I just want to introduce Dr. McCaslin Rodrigo. She's a clinical psychologist at the National Center for PTSD, Dissemination and Training Division at VA Palo Alto HCS, and a clinical professor in the Department of Psychiatry and Behavioral Sciences at Stanford University. She received her PhD in clinical psychology from the University of South Dakota in 2003 and completed her postdoctoral fellowship in stress and health at the University of California, San Francisco, and the San Francisco VA Medical Center. Dr. McCaslin Rodriguez work focuses on understanding factors that impact the quality of life and functioning in individuals with PTSD, and on the development and evaluation and implementation of digital mental health products for veterans with post-traumatic stress symptoms. So with that, I will hand the floor over to you.
Great. Thank you, Chantel. We can go to the next slide, Erin. That'd be great. Thank you. And next slide. So yeah, it's great to see so many folks back after the webinar. And just to echo Chantel, this will review some of the same information because there's so many new folks. And so, you know, if you can bear with us while we repeat some of that, and then we'll go into more depth around certain pieces of the talk. So the learning objectives for today are really to give an overview of PTSD and assessment for PTSD, PTSD treatment and the use of shared decision-making when deciding on a treatment. And then I'm going to take a deeper dive into the resources that are available to learn more about all of this, to receive training in all of this, and then also for self-management resources such as digital mental health tools like mobile apps. And just a caveat, the field of PTSD is vast, and there's, you know, we could probably spend a week going over all of these things. And so if I'm unable to answer your question today, or you have specific patient questions, I would refer you or strongly encourage you to reach out to our PTSD consultation program, which is run through the National Center for PTSD. And I'll give you information about that when we get to the resources section. But they are there to answer any questions around PTSD and provide guidance around treatment and patient care. So next slide. So this is a bird's eye view of the DSM-5 TR diagnostic criteria for PTSD. And this, you know, I just wanted to show this to give you a sense of all the pieces around PTSD. And PTSD is one of those diagnoses that I think we talk more about in our day-to-day life. It's not unusual for people to say, you know, that was so traumatizing, whatever happened that day, without recognizing that there is a diagnostic criteria definition for what trauma exposure is when you're talking about PTSD. So next slide, please. So trauma defined for the purposes of the diagnosis are the following. Next piece. Direct experience or witnessing an event that involves death or threatened death or serious injury or sexual violence. And so the threat of death or serious injury is a big part of the exposure that we're talking about for PTSD. Next piece of this. Next, yep. So learning about the unexpected death, serious harm, or threat of death, injury experienced by a family or close associate. And this needs to be sudden or accidental, violent, really something that, again, this threat of death or serious harm. Next piece, please. Great, thank you. The other piece of this is you can meet this criteria A by experiencing repeated or extreme exposure to aversive details of events. So these are folks, for example, who may encounter distressing or potentially traumatizing events as a result of their employment or their day-to-day life. So this would include exposure to dead body parts or severely injured people, journalists who might be embedded in difficult situations or war zones, et cetera. Next slide, please. Trauma exposure is relatively common. So one study found that 60% approximately of men and approximately 51% of women in the US will experience at least one traumatic event in their lifetime. And there's some other studies that have found these slightly higher rates than that. And, you know, many people will experience more than one in their lifetime. So one thing that has been a piece of debate with the diagnostic criteria since PTSD was first designated or included in the DSM Diagnostic and Statistical Manual for psychiatric disorders in 1980. Since that time, this criterion A, traumatic exposure piece, has been discussed and has been revised. And so what I showed you was the current criteria for traumatic exposure for a diagnosis of PTSD, but that has undergone changes through these different versions. And I wanted to refer you to Dr. Marks's article and colleagues that gives a really nice overview of the debates around criterion A and how you determine traumatic exposure and kind of how that's evolved throughout the history of the diagnosis. As well as some of the pros and cons of, you know, expanding this, you know, making the criteria for traumatic exposure expanded versus narrowed, and things like that, and recommendations for moving forward. It's a really nice article if you really want to understand this definition of traumatic exposure a little bit better. I will say, I apologize, the year on the Marks article should be 2023. And so just to note that when you're searching for it. And when this article came out, a number of folks in the field responded to that with comments and their thoughts. And so you'll find that as well connected to these. One that I'd like to point out is by Dr. Allwood, who gave a response discussing some of the potentially cultural pieces that could be considered as we discuss future iterations of the PTSD diagnosis, and as well as the role of adverse events and cumulative trauma. And so that's a really nice commentary to expand to just sort of expand how folks are thinking about this criterion A for the PTSD diagnosis. Next slide, please. So there's 4 categories of symptoms to meet a PTSD diagnosis, and folks must meet a certain number of symptoms in each category. And so the first category we'll talk about is re-experiencing, or the intrusive symptoms, and folks must meet one or more of these symptoms to have a diagnosis of PTSD. And can you do the animation, please? Thank you. This includes intrusive memories, so having thoughts come up when you don't want to be thinking about this event, it pops into your mind, distressing dreams and nightmares, dissociative reactions, that might be what we discuss as flashbacks, feeling as if the event is happening again, feeling upset at reminders of the event that you might encounter, and physical reactions to cues or reminders. So, you know, if it was a car accident that you were in, you know, being in certain traffic situations might cause more of a physical and emotional reaction, right? Bring this memory up. Next slide, please. So this is a video from the About Face website, which is a National Center for PTSD website. And I'll give the link to this later in the resources section. But the About Face website includes stories from veterans who have generously shared their stories and given their time to discuss their experiences with these symptoms and with seeking treatment, their experiences with treatment. There's also folks, sorry, is just noticing that someone couldn't see the slides. Chantal, I'm not sure if that's a
I'm not sure, because I see like the video that's ready to play.
Okay. Yeah, I also see it on my screen as well. Yeah. But yeah, and so this website does, it has stories from veterans. It also has clinicians talking about the treatments that we'll talk about later. And No worries. And so yeah, let's go ahead and start this video. This is a veteran who has is talking about some of the intrusion or re-experiencing symptoms that she experienced.
I really didn't know that I had PTSD because I was coping with the PTSD through negative ways. And when I stopped using the negative ways or the coping skills that I thought were helping me get through, everything started to bubble to the surface, and I started to have panic attacks and nightmares, and became really depressed, and started to isolate myself from my friends and my family, and just I think the hardest thing that I experienced was I would have nightmares in my sleep, and it would interrupt my sleep, and then throughout the day I couldn't remember things, I couldn't put thoughts together, and I went to the VA hospital, and then they gave me a diagnosis of post-traumatic stress disorder.
All right, the next cluster of symptoms is the avoidance symptoms. And so folks must meet one or both of these symptoms to have a diagnosis of PTSD. The first is avoiding memory, thoughts, and feelings of the event. And you can see how if you're experiencing intrusive symptoms and the thoughts are popping up in the dreams, it makes sense that you would want to avoid thinking about it, right? If it's very upsetting. And also avoids external reminders, so avoids those things that can bring up distress. So next slide, please. So this individual is going to talk, will talk a little bit about his experience with avoidance symptoms to illustrate this cluster of symptoms.
Certain things that used to trigger me off were smells. I now go to restaurants, but prior to that, I wasn't going to restaurants. I was isolating in my room. And one day when I figured out, hey, I need to go get something to eat or I'm gonna starve, I went out and I wanted to go to the restaurant that I normally go to, and I couldn't go. I sat out in the parking lot contemplating if I'm gonna go in, and sure enough, that I got a whiff of a smell that reminded me of Iraq. And I just left and went to a drive-through. That way I wouldn't have to go inside of a restaurant.
Okay, and the third cluster of symptoms, which is new in the DSM-5, negative cognitions and mood. So individuals must meet two of these symptoms. So inability to recall certain details of the event, so not remembering certain details of the event, experiencing exaggerated negative beliefs about oneself, others, the world. So for example, the world is always dangerous, or I'm always unsafe. I was to blame for the event, for example. And distorted blame. Negative emotional states, feeling kind of numbed out, so less interest or participation in activities, feeling detached or distant from others, and just really being unable to experience these positive emotions. Next slide. So this gentleman will share his experience of these symptoms with us.
Yeah, I thought I was worthless. It, it made me feel like, what was I doing here? Why? I'd be better off if I wasn't here. And like I said, that's the first time I tried to commit suicide. I didn't have any friends. All my relationships were gone. I was drinking like a fool. I didn't have any hobbies. Everything I enjoyed just disappeared. I just let them go. I just figured, I don't know what I figured, to be honest, that there was no point in doing anything that I enjoyed because I didn't enjoy doing it. in trying to figure out why, I couldn't come up with an answer. And it was just, for years it was like that.
And then the last symptom cluster is arousal, symptoms of hyperarousal, hypervigilance. So this is where you might see symptoms like being keyed up, being sort of more on edge, more irritable, more likely to become irritable quickly, maybe aggressive or angry behavior, difficulty concentrating, being easily startled. So a door slams and you jump more than other people might. And you might engage in reckless or self-destructive behavior, driving too fast, for example, and difficulty falling or staying asleep. And our last video will illustrate this cluster. Next slide, please.
I wasn't sleeping. I was taking Ambien to sleep, and I was waking up hungover, but without the previous night of partying. I was very hypervigilant when I would sleep. I'd hear everything, I'd smell everything. I can always think that there was something there when there wasn't. My insecurities would take control instead of my rationality. Lock the doors, make sure the gun was loaded underneath my nightstand. Baseball bat next to the side of the house. Kid was tucked in. Blinds were closed. Normal things that the rest of the vets go through.
So and you can see with some of those videos that the symptoms overlap a little bit. So you saw hypervigilance and also sort of that sense that the world isn't safe, right? Sort of comes through in that video. So the prevalence of PTSD. So again, PTSD is one of those things that we see on TV. It's in shows, often written in, and it can make it seem like PTSD happens more frequently than it actually does. But the fact is the majority of those who are exposed to traumatic events do recover. And so it's really a minority of the population that will go on to develop PTSD. That doesn't mean that traumatic events don't impact people, right? In all kinds of ways. And some folks will have acute reactions. But those generally will dissipate early on. And so to have a diagnosis of PTSD, as I showed in that bird's eye view, you do need to have symptoms for at least a month. And so again, this isn't to say that folks aren't impacted by these events, but really to have a diagnosis of PTSD, all of those criteria must be met, and it must be for a month or longer. And when you look at that, these percentages are from a nationally representative survey of about 36,000 adults. And what they found was approximately 6% of the general population was reporting a diagnosis of PTSD, and that the lifetime prevalence was higher in women than in men. When you look specifically at veterans, that rate was a little bit higher for lifetime prevalence, and it was higher among female veterans versus male veterans, as well as younger veterans also at higher rates. Now, whenever you're looking at prevalence, it is a little bit tricky because it depends a lot on the population that people are studying, right? So if you look at different eras, right? If you look at Operation Iraqi Freedom, Operation Enduring Freedom, veterans, you might who are in combat, you might see higher rates in some of the studies. I think some studies found between 10 and 13% or so for that era, as well as some Vietnam combat veterans. Vietnam combat veterans also showed some higher rates. So there's some era differences. Folks have also found higher rates among VA users as opposed to non-VA users. So really taking it with a grain of salt and knowing that the population that folks are measuring this in does make a difference. Next slide, please. Most individuals that have PTSD will also have one or more additional diagnoses. That's about 80% of folks. And so you can see sleep disturbance, depression, substance use, chronic pain are some of those that will show up often. And there are treatments for those as well that are evidence-based and can be used to treat the co-occurring conditions. One thing we're going to talk about treatment later, but they have found that using evidence-based treatments for PTSD can have a positive impact on some of these other conditions as well. Next slide, please. So we'll talk a little about assessment of PTSD, and I'm going to talk about the clinical practice guidelines a little bit later as we get into treatment, but just to note that assessment of PTSD is also included in clinical practice guidelines. And what I'm talking about today is in those guidelines as recommended assessment and screening tools. They do list the screening tools that are strongly recommended because of having evidence of their validity. So one level of assessment of PTSD is PTSD screening. And this is really what we think of as a broad assessment of risk for PTSD. And if you're positive for a screen, right, you would refer on for further assessment and say, okay, there's some indication that you may have PTSD, so let's get you checked out for that. One of the validated measures for screening is the primary care PTSD screen for DSM-5, the PC-PTSD-5, and this has 5 items. And generally, if you're positive on 3 or more of those, you would say, let's get you checked out and refer you on for more assessment. I'm also putting the link here for the National Center's website, ptsd.va.gov. They have an incredible amount of information related to the screens that I'm talking about today, as well as trainings and how to use them for providers and others. And I just saw a chat pop up, so I apologize, a little distracted there. But I wanted to actually address that. So yes, these are all publicly available screening measures, and not just for military and service members and veterans. And so yes, so really can be useful for any folks with PTSD. Okay. So self-report measures, these are a little more in-depth than the PTSD screening measures, a little bit longer. They can be used for monitoring change, sort of getting a baseline of how somebody's doing and then watching that through the course of treatment and seeing if there's improvement. Again, it's not really used to diagnose PTSD. It's not the gold standard to diagnose PTSD. But one of the symptom self-report measures that is often used and is validated is the PTSD checklist for DSM-5, the PCL-5. This is 20 items and the scores range from 0 to 80. It asks folks about all of those symptoms for the diagnosis and how often they've experienced those in the past month. And so this again is a frequently used measure for monitoring change and to be able to check in about symptoms. And there's a link there for the National Center's website again that describes the assessment measure, and all of the information about how to get the measure and how to use it is also on the website. Next slide, please. So the gold standard is really a diagnostic assessment, and this would be a full-scale diagnostic interview that's conducted by a trained individual who knows how to use this measure, has expertise in using the measure to diagnose PTSD or to measure PTSD. It measures symptom severity or intensity, I guess you could say, and frequency. So both of those in order to be able to have a sorry, I'm just going to close out the chat for a second. In order to be able to come up with a full score of severity for the diagnosis and to be able to diagnose someone. And because this is a more involved measure, right, it takes some training to be able to use it. There is a CAPS-5 training on the National Center's website. Can folks hear me? I'm seeing some things in the chat. Chantel, is that?
Yes, I can hear you. Yeah, I'll answer that.
Okay, thank you. So yeah, so But yes, there are trainings available, and there's also trainings through different organizations as well, like the Center for Deployment Psychology, and I'll provide the link to their site towards the end. One thing to note when we talk about assessment of PTSD and diagnosis of PTSD is that it's a very heterogeneous diagnosis, which means there's a lot of different ways that somebody can look with PTSD. And so, sorry, I'm just going to close out the chat there. And so if you, so it doesn't look just one way. In fact, you saw the number of symptoms there, and there's a study that was done by Gallitzer, Levy, and Bryant that looked at used mathematical modeling to see how many different ways can PTSD potentially present based on the number of symptoms that we have, right? And they found over 600,000 different ways that someone could have PTSD. So it really is important to do a careful and a comprehensive assessment to really understand how that individual is experiencing PTSD and to understand what kind of symptoms might be primary for that individual. So the link at the bottom of this slide is to the clinical practice guidelines, which discusses these assessment measures, discusses why certain measures are recommended over others, and can give you more information about that. And again, for information on how to get the assessment measures and more information about them and training, I would go to the National Center for PTSD website. You could also contact the PTSD consultation program, which again, I'll give you that link at the end of the talk. Next slide. All right, so this is our first question. What are some of the challenges you've encountered in assessing PTSD? I'm curious what folks have, sort of what your thoughts are and what thoughts you're having as we're talking about this in terms of assessing for PTSD, for a diagnosis of PTSD. Anyone? Let's see.
Feel free to raise your hand or to type in the chat.
I'm Jay. I'm happy to.
Jay, okay. Sorry,
Yeah,
I lost you for a second.
Sorry,
there.
trying to turn my camera on here.
Okay.
Yeah, we're a small intensive outpatient treatment program for substance use disorder. We primarily support veterans. We're part of the VA's community care network, and we also started a nonprofit here to help with all the other things that veterans might need in addition to that. And for us, we've seen the substance use mask a lot of those symptoms, and also, is it a coping strategy for the PTSD? Is it a separate issue? Usually it's just intimately related, and it's, we have to treat both aspects of it. But for us, we found that usually getting about 30 days sobriety helps us a lot, because then those other symptoms become more clear, and establishing that bond of trust, establishing some trust so that people will actually talk about what those issues are. I'm a veteran myself. I'm in recovery myself. And I know the warrior ethos is one of the big things that gets in the way. We're trained in the military. The military does a great job of assimilating people and training us to be professional and dependable and reliable and part of a team. And I'm never going to let down the team. And the mission comes first. And then, in an instant, we become civilians again, one way or another. And all that goes away, and that support network goes away, that team goes away, and we're on our own, but that ethos remains. And we continue to feel like we have to figure this out on our own, and we don't want to let the imaginary team down now. And it's really, really hard for us to talk about those symptoms. And I can tell you that, the three hardest words in the English language are often, I need help. So
yes,
I think for us, we may see hints and signs, but it takes a little while to get that therapeutic alliance established so that people can really talk about how it's impacting their lives, and then to, chip away a little bit more and find out, okay, yeah, this is probably what's going on. These symptoms are related to post-traumatic stress as opposed to something else. So that's been our experience.
Thank you so much for sharing that, and thank you for your service and the work you're doing. It's really important work, and yeah, and I think you're absolutely right. It is, trust is absolutely essential, and being able to discuss things that you may avoid talking about, may not want to talk about with anyone. And feeling safe in with the person you're going to be working with is really critical. I would say, I'm going to talk about some tools a little bit later, our mobile apps in particular that, do have, can sort of be used as an adjunct to treatments, other treatments, for veterans to acquire some tools for coping with PTSD symptoms, as well as kind of monitoring PTSD symptoms and tracking that information. So thank you so much for that, Jay.
I also want to mention, just going through the chat, Ronald wanted to share as well that some of the issues found were with getting the right diagnosis as far as like grief, medical issues. I don't know if you want to touch on that.
Yeah, that is challenging. And I think, again, that's where this the clinical interviews can be so important, because it's hard to really understand the complexity of somebody's presentation from a self-report measure. That can be really difficult. And a lot of the folks who've gone through traumas, especially if it's multiple traumas, the presentation can be very, very complex with a lot of different things going on. And certainly grief for veteran populations is in loss while serving. It can be very profound and need to be addressed as well. And there are the treatments that we'll talk about, depending on the person's presentation, may be appropriate for that. There's also treatments that are more focused on traumatic grief and loss. And for, again, because there's so many different ways that folks can present, there's so much comorbidity often, or co-occurring problems or conditions, that it can really be helpful to consult with folks and just get some additional information or additional input from experts in the field. And so again, I can't plug it enough, but our PTSD consultation program really has those experts on hand to talk through some of these challenges and to refer folks to these different resources for some of these co-occurring concerns, or even to talk through, is it the traumatic grief and loss that we really need to focus on, or are there other events that we want to start with? And so so absolutely, just to validate that this is often, the presentation is very complex for these folks.
Thank you. I see two more comments, and then I was thinking after we get those two, we'll move on to the second part. The first one is from Maria Crowley, and the second one is from Jessie La Costa, and I hope I didn't mess that up.
No, that was fine.
Thank you. So for Maria, who is actually going to be our presenter on TBI next month, she made a comment about how sometimes in brain injury community, it can also be intertwined with PTSD. So kind of touching on how that maybe can overlap, or maybe there could be some mix up, if you have any thoughts on that to add.
I would just say absolutely. Thank you, Maria, for chiming in on that. And feel free throughout this, if there's other thoughts that come up that you could share with the group. Yeah, absolutely. TBI in some of the post 9/11 conflicts, folks who, for example, had a blast injury, it wasn't, it's very likely if they had a TBI, they may also have PTSD or some psychological symptoms related to that experience as well. So there's some overlap with those pieces, and and that's, yeah, it just, I can't stress enough the need for a really comprehensive assessment to really understand what somebody's dealing with. Great, thanks. And Jesse LaCosta, what was that? What was your thought, your question?
I'm not even sure that I remember it anymore. I think I may have shared twice or in two different places. So I'm in probably a different situation than many. I am not working at a nonprofit. I've been trained in a lot of therapy modalities, but I'm actually a coach, but I've been working with veterans for more than 10 years. Initially, we started with just transition, and then we worked through what we call like professional development and transition, and work with spouses and partners and even some active duty. And I remember being at a seminar conference, it might have been 5 years ago, and we were talking about the transition alone as being actually traumatic. Now, whether that actually would precipitate what we would define as PTSD or not, that's not necessarily always the case. However, there are people that have PTSD that are what a colleague, I think it was last week, called high functioning, not showing any signs of PTSD. And I definitely see that a lot in the transition place. So it's not, so as a coach, I refer out. So I am not going to treat the PTSD, but I still need to be aware and to be able to assess. And so for me, a lot of the times, if I don't see what I've been taught as the standard, manifestations, I look a lot for, continued lack of purpose, continued lack of connection with community, continued lack of decision of career, continued lack of, desire to even want to actually transition. So, and I forget his name, and I apologize, a gentleman who was speaking earlier who talked about recovery and being a veteran, and this bridge that goes from being active duty to the civilian life is something that I often feel like isn't talked about enough as being extremely traumatic. So that was just kind of what I was sharing. And I mean, this isn't what I do full time. It's what I do sort of part time and where I give back, but been doing it for more than 10 years. And I see it a lot. I just see it a lot.
Yeah, well, thank you so much for that, and for your work, Jesse. It's really important. And I think, I have a couple different thoughts, actually. One is, what you're discussing in terms of transition, frequently that would likely not meet the definition of a traumatic exposure for the diagnosis of PTSD, but that doesn't mean that it's extremely stressful and impactful for folks. And it doesn't mean that things might not happen throughout that process that would make it rise to a traumatic exposure. I do think that transition period, just like you were saying, Jay had brought this, the earlier speaker had brought that up as well. And it is, there's a lot of losses that happen in that period, and a lot of, loss of community, loss of maybe sense of safety, loss of your peers, loss of purpose sometimes and meaning. And it can be a really difficult time for folks, as you are so familiar with, I'm sure, in your work. So going back to what Jay had said again with the strong warrior ethos, right? I think sometimes there is, folks may minimize because they feel like they should be able to do this. They feel like they should be able to keep going in the same way. But there's also strengths that people have. So for example, some people may not have, some people may not have social support. They may not have anybody, right, who's supporting them. Other folks may have a pretty strong network that can help support them through that difficult period. And those types of things can make a lot of, can make a big difference. I was just at an outreach event for student veterans, and there was a panel of student veterans who talked about their experience transitioning out of the military. And what struck me, there was maybe 6 or 7 folks, and what struck me was that there was such diverse experiences, right? There were some that had a really, really hard time getting back on their feet. There were some that it was a little bit easier for. There were some that were doing okay and then suddenly took a dip. I mean, there were different trajectories for that. And I mean, happy to report they were all doing very well at the time of the panel. They were really success stories. But, you know, looking at those transition periods, I think is really critical. And the VA does have some programs for that. They have transition care managers at each VA. They also, there's a program for student veterans at the VA called the Vital Program that clinicians actually, in the case of the San Francisco VA, they actually have an office on the campus of City College of San Francisco where they will meet with student veterans and help them through the transition to school, and with whatever they need for that, to try to make that a smoother transition and support their recovery while they're going to school. But yeah, sorry, long-winded answer, but I think you're absolutely right. It's a very important area, and really appreciate your work in that. Yeah.
Thank you so much for that. I think we're ready to move on to if there's no other questions, to move on to the second half of your presentation.
All right, so next, thank you everybody for your questions and thoughts, and next slide. All right, so we'll talk a little bit about PTSD treatment and using shared decision-making to decide on treatments with veterans and service members. Next slide, please. All right, so shared decision-making is a collaborative process. So it's a process not, and I'll talk about some tools to help that process in a little bit, but to help patients make informed decisions about their care. And so in the clinical practice guidelines, they suggest using shared decision-making in the process of working with your veterans. And so this really has a history in the medical field, and there's papers and research on shared decision-making in the medical field, but not as much in the mental health field. It's sort of been focused on more in the past 10 years or so. There's a lot of folks at the National Center for PTSD who have really worked hard on this area and done some research to see how best to do this with veterans experiencing PTSD. So shared decision-making is really what it sounds like. You're sharing this with your patient, and sort of what treatment you're going to end up doing. Sort of at the outset, offering a patient that, you know, you do have a choice. There are options and you have a choice. And how much somebody will want to be involved in their care varies. So one study that was done by researchers at the National Center for PTSD found that the majority, but not all, really wanted that active role in their care. And even within those that did, it kind of varied between, I would like to be the decider on what treatment I do versus I really want to make this a collaborative decision between my care provider and myself. And so really up front, again, just saying, you know, you have a choice, there are these options, and providing multiple options, saying, okay, here are what we know about what treatments are most helpful for PTSD. And this is what our clinic can offer. And then really taking time to think about the patient's preferences and their values in that. As you describe the treatments, are there pieces to those treatments that are just not possible for the patient? So considering their context. So for example, if you have a veteran who is also a working mother who has no childcare and can't make certain appointments or just doesn't have the time to do certain things that some of the treatments might require, then that treatment may not be the best choice for them. But making sure to weigh those factors and talk about them throughout throughout the process of deciding on a treatment. And what they found, they did do, Larson and colleagues at National Center did this qualitative study of 12 veterans and 10 providers. And they found that generally among these folks, patients were satisfied with this, but they often did not remember much about the options that were presented. So they appreciated the process, but when asked to really recount what the treatments entailed, they couldn't really remember much about those options. So using tools while you're doing this process can be very helpful. So next slide, please. So in that spirit, the National Center for PTSD has a decision aid, and it can be super helpful and used in a number of different ways. Veterans and patients, service members and veterans and other patients as well in the general public can use this. It's an online tool. They can go online and start to click through this and get a sense of what might be the right treatment for me. And it will personalize choices based on what their preferences and their values are. It will create a summary for them of this is what you said you might prefer, and this is the treatment that sort of has these components. And that can be used, it can be assigned to someone who's not currently, if there's no time in treatment to really look at it that day, they can look at it later and bring it in. They can print out the summary from the decision aid. And the decision aid, so you can see on the side on the left, there's different sections of the decision aid. So the first section is learn. So that will provide information about the evidence-based treatments for PTSD that I'll talk about in a moment. It doesn't cover all the treatments for PTSD, but really focuses on these 3 that were recommended in the clinical practice guidelines. But it has videos for folks to watch about describing these treatments, and really aims to inform them about the treatments. And then the patient can compare. They can kind of like or thumbs up pieces of the treatment or components of the treatment that they like in that, and it'll compare these side by side. So it'll show them a chart that compares the treatments and what pieces they seem to prefer or value, or that might fit best for them. And then it will create a summary for folks, like I had mentioned before, that they can bring in to treatment to share with their provider, or the provider and the patient can do this in session together to help guide the shared decision-making process. Next slide, please. So moving into treatment itself, the clinical practice guidelines that DoD and VA have released in 2023 considered 4 domains when they were making recommendations. So one was the confidence and the quality of the evidence, and this relied a lot on the research that's out there, so the clinical trials research as the evidence for treatment effectiveness. They looked at the balance of desirable and undesirable outcomes, so benefits and harms. They also took into account patient values and preferences, and they thought about other things as well, such as resource use, equity, acceptability of the treatments. And again, you'll find the link for the clinical practice guidelines here throughout this talk. It's the healthquality.va.gov site, and they also have guidelines for a lot of other types of diagnoses and mental health concerns. And you can print them out in different modalities. There's quick references, there's summaries for providers, and then there's the entire clinical guidelines that you can print as well. And the group that really worked on this were experts from the DoD and VA who are experts in PTSD. Next slide, please. So in the clinical guidelines, they had strong recommendations for the following. So cognitive processing therapy, prolonged exposure therapy, and eye movement desensitization and reprocessing therapy. They also strongly recommended the paroxetine, sertraline, and venlafaxine as pharmacotherapies. And they noted there's a strong recommendation for the psychotherapies over the pharmacotherapies. For a strong recommendation, there had to be strong evidence for those pieces that I discussed and for effectiveness of the treatment. There's also some treatments that had evidence, but it was weaker evidence and didn't lead to a strong recommendation, but are called suggested treatments. But these three are the strongly recommended treatments. Next slide, please. So I'm going to go through each treatment and sort of give a broad overview. And again, at the National Center for PTSD, you can find more information about these. There's videos, there's trainings, there's webinars. There's all kinds of information if you'd like to have a deeper understanding of any of these or receive training in any of these. Cognitive processing therapy is, and I should note that these are all individual manualized treatments that are approximately 3 months long. EMDR can be slightly shorter than that. Cognitive processing therapy is, again, 12 sessions weekly, 60 to 90 minutes each. And it really, one of the main components of cognitive processing therapy is evaluating and changing upsetting thoughts, or what they call stuck points related to trauma. So this idea that changing beliefs or thoughts can then lead to changes in feelings and behaviors. And it really focuses on 4 main themes, or themes related to changes that take place following trauma in our beliefs, right, or in our thoughts. And these themes relate to often self-esteem, power control, safety, sense of safety, and trust in others. And so those are some of the main themes that this treatment really addresses. You may be asked to write about the trauma. They found that it can be effective even without writing about the trauma. And so that's really, again, one of those places where you might use shared decision making to discuss whether that's a component of the treatment that you're going to include or not. I think you'll challenge these beliefs or these stuck points throughout the therapeutic process. The second treatment that I'll discuss is prolonged exposure therapy. And so this is also brief, 8 to 15 weekly sessions, about 90 minutes each. And the idea with this is that you're approaching your trauma-related memories. If you remember from the diagnosis, there's a real understandable desire to avoid trauma-related memories, feelings, and situations, right? But that can be disabling for people and can really make your life narrower and narrower and make it difficult to function. And it also doesn't, the memories will continue to be elicited and not, if they're not processed. And so this really is about approaching the trauma-related memories, feelings, and situations that the person is avoiding. They're provided with a breathing technique to help manage some of the anxiety. And there's 2 types of exposure that folks undergo. So there's in vivo or real life exposure, where they actually identify the events or the things in their life, situations, people, activities that they are avoiding because it might bring up memories of the traumatic event, but that they would like to engage in. And so you would have folks list these out and in a hierarchy and start maybe with the easiest thing to conquer and have them approach these situations in a very systematic way. You would never have somebody do something that's objectively dangerous. So these are safe situations that you would have folks encounter and start to tolerate in a gradual kind of way, with the idea that you can, by the end of the treatment, folks will be able to be in many of these situations without experiencing these memories or the physiological arousal in the same way. The second piece of the treatment is imaginal exposure. So talking through the details of the trauma. Again, really with the idea of processing through the trauma, you would listen to tapes of the imaginal exposure at home as homework. And I should note that both prolonged exposure and cognitive processing therapy have homework. So cognitive processing therapy has worksheets related to these stuck points and working through these different areas. And so that's something that, again, in shared decision making, you might bring up as, is this something that's feasible for you to be able to do these assignments outside of your session? And so with prolonged exposure therapy, again, you're talking through the details of the trauma. Next slide, please. The third treatment is eye movement desensitization and reprocessing, EMDR. This one is about 1 to 3 months, so weekly sessions, 50 to 90 minutes, and again with the idea of processing the trauma. So the individual is asked to pay attention to a back and forth movement or stimulus while they call to mind the memory that is upsetting or the target memory. And they're asked to think about the trauma during the session. The other treatments that were suggested in the guidelines that had weaker evidence but could still potentially be helpful are written exposure treatment, cognitive therapy for PTSD, and present-centered therapy. So there's also those options. And again, although the 3 treatments I discussed earlier are really sort of have the strongest evidence base, there may be reasons that the person doesn't necessarily want to do those treatments. And so exploring these other treatments and how those fit with the individual's preferences and values in their life is valuable, and those treatments may be helpful as well. So next slide, please. All right, so I'm going to move on to digital tools that might be helpful while someone is both in treatment as well as if they're trying to manage symptoms on their own. And in particular, I'm going to talk about the National Center for PTSD Mobile Mental Health program. So just as, just before I get started with this, I'd like to note that the mobile tools do not replace treatment. They can be used by anyone for self-care. We do create the products for veterans and service members. However, they are publicly available. They're very useful for the general public. They're free and they're private. And so they can be used by anyone out there in the public. They can be introduced by anyone, including in settings by staff outside of mental health, which from a public health standpoint can make them very useful. And they can be a bridge to mental health care. In all of the apps, there's a resource section where folks can connect to care and can learn more about seeking care. Next slide, please. So again, just to note that these are free and publicly available in the app marketplaces. They're private. We're held to very strict security standards in the VA and privacy standards. And so the data is really stored on their phone. And they're accessible without Wi-Fi or data, only to download the app. That's the only reason they really need them. The apps are evidence informed. So we take what evidence is there and we work with that. And we try to make them easy to use with text in plain language. And we are always open to feedback, and I'll give you that information as well. If you have feedback on our mobile apps you'd like to share, we do definitely take that very seriously. Next slide, please. So there's different types of mobile apps that we create. So we have self-care apps that are really for self-management. And for folks who maybe they aren't in care yet, but they're wondering what might be helpful for them. And so I'm sorry, I'm seeing a question in the chat, and I'll get to that as soon as we stop. We can address that during our next question and answer period. But looking forward to discussing more. So self-care apps, including PTSD Coach, which is sort of our flagship app, which was the first app that National Center released. And I'll talk a little bit more about that in a second. Then we have Family Coach, which is for folks who have someone in their family with PTSD, someone they care about or love, that they want to learn more about PTSD and how to support that individual. We have Mindfulness Coach. Yep, here's PTSD Coach. We can go right to that. So I will say, can we go back real quickly before we do this one? But there's a lot of different apps. There's ones for anger, ones for sleep. We also have treatment companion apps. So for providers who are doing these evidence-based treatments like CPT or PE, there are apps to go along with that where the worksheets and are stored on the phone. They can do the worksheets on the phone. They can monitor progress. They can track their symptoms. They can access recordings on the app, etc. So just to note that there are those as well. Next slide. So PTSD Coach, again, is just a fantastic app for folks who want to learn more about PTSD. There's a lot of psychoeducation in the app. They can track symptoms with the post-traumatic stress checklist. Five is in the app, and so they can monitor their progress. It can show them graphs of how they're doing. There's tools for managing symptoms, and they can favorite their tools. So if they find things that really work for them, they can make sure those show up first. There's support resources in the app as well. Next slide, please. And sorry, actually, before we do that, you'll notice the QR code is there if you'd like to download that app and kind of take a look at it. You can download it using the QR code. Next slide, please. This is just a quote from somebody who had used the PTSD Coach app and how you might use it. So being able to use the tools in the middle of the night, right, to manage symptoms or to bring down arousal was a way that this individual found it helpful. Just an example of that. Next slide, please. So here's where you can see assessing symptoms. So you can assess your symptoms with the screening measure or the self-report measure, and it'll show you your scores over time. And you can set reminders. So if there's somebody who's in treatment and you say, let's see how you're doing weekly, if you can maybe set a reminder to take those assessments weekly so we can track your symptoms consistently, for example. Next slide. One thing that was more recently built into PTSD Coach is the safety plan, which is on the left menu. And it's based on the VA Safety Planning Intervention Manual. And it was done in collaboration with many key stakeholders who are experts in this area, who helped to work on the VA's safety planning procedures. And it mirrors the paper plan, including all the steps, prompts, or resources, and also with some psychoeducational material. And again, compliant with VA privacy rules in Section 508, but that is something that might be helpful for those folks who also struggle with suicidal ideation. Next slide, please. We also have PTSD Family Coach. Again, I mentioned for folks who want to learn more about PTSD, learn more about resources that are out there, learn about strategies for self-care and supporting their loved ones, and assessing PTSD and symptoms of PTSD. And there's a QR code there if you'd like to download that app and check it out. Can leave that there for a second. Okay, next slide. So if you work in a setting where you'd like to inform people about mobile apps or what's out there, or you do outreach events, or you just for your own information would like to have things on hand that describe the mobile apps in a little bit more detail, we have promo items, we have brochures, we have posters, we have prescription pads for mobile apps, we have other things that we develop periodically around the mobile apps. Each app that's developed does have a brochure. It does, and materials that go along with it to help folks navigate the app and understand what it's used for and how best to use it. And all of these items are free if you go to the government publishing office, and I put the link there. You can order any of the items you like. They're all free. They can ship anywhere, and they typically get there around in a couple weeks. Next slide, please. The apps also have accompanying videos again, they're very brief, 1 minute long videos that sort of just give an overview of the app. We'll take you through the major pieces of it. And this can be helpful for veterans, for patients, for clients who it's just kind of overwhelming. Like there's a lot of stuff in this app. I'm not quite sure how to use it. It'll take you through the major pieces of it and show you step by step how to go through the app. So if there are apps that you're interested in using, I think that this playlist is great, and you can share it with folks as well that you're working with. Next slide, please. The mobile mental health at va.gov email address is there if you have any questions about the apps, if you have suggestions for the apps, if you want to report any bugs that come up, because sometimes if there's updates to operating systems and things, sometimes there's bugs that come up or there's issues, and we want to hear about all of that. There's also some websites there that are related to the mobile apps team that you can take a look at. So the Tech into Care website is public facing, and it's on the National Center for PTSD larger website. And the Tech into Care team has CE lecture series and webinars for folks within VA and outside of VA, where they have experts come in to talk about digital health and PTSD. They also have a podcast that you can see there on this list, and the other links as well. Next slide, please. All right, so I know that was a lot of information. I realized we discussed a lot of things other than shared decision making. So if you do have questions along the lines of other things we discussed, feel free to ask those as well. But the question on the screen is, what has been your experience of using shared decision making? Chantel, I'll turn it over to you. Any other thoughts?
Yeah. I think while people are thinking about that, there are actually a couple things in the chat that we can point out. So Jesse mentioned people who are with high functioning PTSD, and that they have seen where like people like can have it, but they don't really show any signs of it. Do you want to touch on that a little?
So we talked a little about that, I think, when we were discussing the last question around transition. So, you know, and there's many reasons why someone may present as higher functioning. I mean, there's a lot of stigma still around mental illness. Jay had brought up the warrior ethos earlier, and sort of this idea of wanting to look okay, or not wanting to show that you're hurting or may have PTSD. But there's also things like social support, you know, even as simple as if your sleep is good or if it's terrible, right? That can impact your functioning. There's a lot of factors that go into how you're able to function, even if you are dealing with symptoms. And so I would, you know, it can be there's not just one reason, but it can be complex, right? Around the factors that sort of play into that presentation.
Thank you. So there's a couple other things, but I'm going to touch on one question that I keep seeing reoccurring. So slides and recording will be sent out in an email to everyone. So if there are QR codes you missed or links that you missed, you'll be able to have access to those, because there's a lot of people that see the different resources you put in there wanting to make sure that they can get a hold of those. Another item that was touched on, so two different attendees mentioned the and I'm probably pronouncing this right, stellate ganglion treatment.
Yes, so I personally don't have experience with that. I wouldn't be surprised if it's in the guidelines, and I'm so sorry that I don't have that off the top of my head. But in the guidelines, you will see if it's if there's enough evidence to recommend it or not. Or so there's so let me just back up for a second. So in the guidelines, there's there's the treatments that are recommended that have strong evidence, right? There's treatments that are suggested that have evidence, but it's weaker evidence, right? And then there's some treatments that are there's just not enough evidence to weigh either for or against. And so those fall under insufficient evidence, and there's a number of treatments that fall into that category. And then there's fewer that actually there's evidence that they're not recommended, right? But there's a lot of treatments that fall into that insufficient evidence piece, and I might check the guidelines to see where that falls, or if that falls in there. So yeah, so that I would check the clinical practice guidelines. You could also contact the PTSD consultation program, because they may have gotten that question before, and I'll be giving you their email and their phone number, but they might be able to give you a better answer for that. Thank you.
Thank you. So I will reach back on our facilitated question. Does anyone want to share experience that they've had using shared decision making?
You know, I actually haven't used shared decision making at this point. This is obviously a new tool that I want to share with my veterans.
Mhm.
But I can tell you that most of my veterans are benefiting from the therapeutic part rather than the medication or pharmaceutical
Um,
portion. I found that to be true just based on my anecdotal experiences. But I do think that these apps would be particularly appropriate as a supplemental tool
mhm.
as opposed to a primary tool. The
Yes.
example that you gave earlier about the veteran having an issue like in the middle of the night, I think if that person has already had some ongoing therapeutic sessions, I think this would be a bridge until that person can kind of talk to their regular therapist on a routine basis. So yes, I definitely want to use this as a resource to refer to my veterans.
Thank you, Keith. Yeah, I 100% agree with you. I think that's, and that is, they looked at digital mental health tools in these clinical practice guidelines, right? And they did find it's one of
Mhm.
those things where there's not enough evidence to say whether it can stand on its own or not. There's insufficient evidence, and it's not
Right.
recommended as a primary treatment, right? So, so you're absolutely right that as a supplement to treatment, as a bridge to care, as an adjunct tool when you're doing the
Mhm.
treatments, absolutely. Thank you so much for sharing your experience, and thank you for your work. Yeah.
Sure, you bet.
Thank you. I feel like we have time for one more. If anyone wants to add on their experience using shared decision making, or if anyone has a question related to any of the presentation. So I'll give a pause for that if anyone has one. And if not, we will move forward. All right, so I guess I don't hear anyone, so we'll go next slide. And these are
Great. So
your
we'll talk. Oh, sorry, Chantel. So we'll talk more about resources. So this is where I'm gonna. And I apologize, sort of a not. It's a lot of resources. But if you have any questions, you can always email me. You can always reach out to me or the PTSD consultation program, which I will give you the information for. Next slide. So again, I keep bringing it up, the National Center for PTSD. There's their website, and you can see on the left menu, there's just so many different domains or areas, right? So there's an area for family and friends, for providers, and so whatever is of interest to you, you can drop down, and they have educational materials, they have trainings, videos. Really, I mean, it's just there's so much information in there. That yeah, I highly recommend just going and exploring that. If you're interested in publications on PTSD, they do have PTSD pubs, which you can see there on the left. That's a database of all the available literature on PTSD, the PTSD publications or scientific literature. So I think that's a great place to explore and to learn more about PTSD and PTSD treatment. Yeah, next slide. So here it is, the PTSD consultation program, and this is for providers who treat veterans or folks who are, looking for resources to help a veteran. They have an email address, they have a phone number, and they have their website. And they also have, if you go to the next slide, actually, that will list some of the resources that they have. So here's some examples of things you can ask about. The consultants are all experienced senior mental health professionals and other health professionals, and really just a great resource for consultation. They have free continuing education lectures, and they archive those. There's some that are really great great lectures that are available that you can take a look at. And yeah, you can ask about all of these things and talk to them about what's available for resources. If you just need a resource and aren't sure one exists on some topic you're looking for information on, again, feel free to reach out to them. This is kind of what they do. They're always answering these questions. Next slide, please. We have some online courses at the VA as well for veterans for some of these conditions or problems that folks with PTSD might also have, so or concerns that they might have. So, and not everybody wants a mobile app. Some folks would rather do things on their computer. And so Path to Better Sleep, for example, is a program about sleep that is based on cognitive behavioral therapy for insomnia, which is an evidence-based treatment for insomnia. Similar to our mobile apps, Insomnia Coach and Cognitive Behavioral Therapy for Insomnia Coach, CBTI Coach. But the modality is just a little different because it's an online web program. But you can see that there's different concerns addressed through these different programs. Next slide, please. This is for family members. It's a course that's also on the National Center for PTSD. If you go into Family and Friends, this course will come down. It's a web-based course on family members who have or a loved one with managing PTSD and trying to cope with these things. Next slide, please. About Face is where the videos we saw earlier, these veterans who've generously donated their time and their stories to try to help other veterans understand kind of their treatment journey and what treatment has done for them, as well as clinicians talking on the treatments, etc. I would definitely go and explore that. Next slide, please. You may be familiar with Make the Connection. It's not PTSD specific, but similar to About Face, there's veterans discussing their symptoms, their experiences in treatment. And it's, while there are veterans with PTSD who talk on this or share their stories on this website, there's also more of a range. There's folks with other diagnoses and conditions as well. Next slide. Center for Deployment Psychology is another group for military and service members. They provide a lot of trainings on evidence-based psychotherapies. They have podcasts. They have a lot of training resources. One thing I'd like to point out is they also have a lot of resources on military culture. So if you're trying to learn about military culture, you know, I think it's important if you're working with service members and veterans to have some understanding of military culture. They have some resources on the Center for Deployment Psychology website. Next slide. I mentioned the podcast that our mobile apps and Tech into Care team put together, and it's these are very short, bite-sized episodes on different topics about PTSD and digital tools, and it's available on most podcast platforms. Next slide, please. All right, so thank you. And I'm happy to answer any questions, happy to respond to emails. I'd like to acknowledge some of the courses that are on the PTSD website. If you go to them, train.org is where it will direct you to for these courses where you can earn CEs if you're a provider, or you can take them without CEs if you don't need that. So yeah. So thank you so much for your time, and thank you for your questions and your thoughts and your work. Much appreciated.
Thank you so much for your time as well and for your presentation. And there is a little bit more. So next slide. So everybody loves homework. So there is optional homework as well. Taking from all the different information that Dr. McCaslin Rodrigo sent out to you, there's also if you would like to scan the PTSD coach or the PTSD family coach and just kind of take some time to actually explore what that actually entails and how to navigate it. That is something that you can do, and I'll leave that up for a little bit for anyone that maybe wants to scan it with their phone. And again, just repeating, people will be receiving a copy of the recording. So if there's anything that you missed, you'll be able to review that or something you want to hear again. Additionally, there were a lot of wonderful resources and information in there that you'll be able to pull from those slides as well. So I'll give it a little bit more, and then we'll go to next slide, please. All right, so the next session, so it's going to be session 2. We're going to have Maria Crowley here, who was actually attending today and had a really great insight regarding TBI and PTSD and how those can kind of be seen and intertwined in some ways. So she's going to be talking December 19, specifically on TBI, traumatic brain injuries. And that is going to be the same time, so 2 to 3:30 p.m. Eastern time. Next slide, please. So with that, just want to say thank you. And again, thank you so much, Dr. McCaslin-Rodrigo, for your time today. And if anyone has any questions specific for us at the SMVF TA Center, please feel free to reach out to us. Thank you so much.
Thank you.